We cover over 200 care homes in Hull and East Riding, about 6,500 residents, and we wanted a parity of service for patients living within their own homes, but also for patients in care homes.
Initially, we thought the best people to be aiming this at was other healthcare professionals. However, it soon became clear as well that we needed to open it up to care home staff directly.
We also opened up the line so that members of the Yorkshire Ambulance Service team could also ring us, so paramedics would ring the line for support when they were faced with a call out to a patient in their own home or in a care home.
The response line has been a great support to our clinicians as they now have access to expert clinical advice for frail patients.
When we ring the Frailty team, I feel like the GPs respect what you say, they value what you're saying, and they appreciate that you're having the face-to-face contact.
The partnership working here it's been, in my personal experience, the best example of any partnership working in anything that I've been involved in the NHS. Myself and colleagues have been leading on a project in Hull at the Jean Bishop Integrated Care Centre. We developed a model working as a multidisciplinary team, supporting patients living with frailty in Hull in a proactive way. And we now wanted to move on to a more reactive model. And obviously then the COVID crisis hit in March. So we accelerated this in a very short space of time. We put an operational model together within 1 week. And we were fully operational by March the 23rd.
We set up meetings with paramedics, and then they were able to send out repeated communications advertising the change in the service and get it added to their clinical pathways list. From a primary care perspective, we had regular meetings with the CCGs and then the clinical directors of the primary care networks across Hull and East Riding, and that was both to discuss the practicalities of the service and to agree the principles behind the clinical guidance and care that we were proposing to deliver.
We work collaboratively with both CCGs to gain direct access from GP practices to their patient care records. If we didn't have access to those records, it'd be very difficult to make clinical decisions in an urgent way without direct access. So that's been game-changing for us.
Prior to the Hull and East Riding Frailty response line, our clinicians had very limited options when responding to a person living with frailty. Of course, they could contact the patient's general practitioner, but in most cases, they would have to convey the patient to the emergency department. And as we know from lots of research, emergency departments are not the best place for frail patients. Our clinicians enjoy clinical conversations with specialists to determine the most appropriate course of action and to devise a care plan for the patients.
The Frailty line asks about everything about the patient. It's not just how they're displaying with the clinical presentation. It's also they're mentioning and asking about the social care sort of package around the family support.
Okay. Because we were able to get in place rapid access, end-of-life care, including just-in-case medicines through using runners, we were able to do electronic advanced care plans. So this meant people died in their preferred place of care 94% of the time when they had contact with our service, and that compares nationally to 49% usually. So that's one of the things that we were really proud of, is being able to support people to be cared for and die where they wanted to be.
I feel like YAS clinicians are getting better at recognising end of life, and that because we've got these clinical pathways now in place, we feel better supported and keeping the patients at home. It's a better patient outcome. The patient's able to stay at home or stay in the community.
Okay. And then what are the observations at the moment, please?
I often find that the paramedic crews in particular have already really decided what they think in collaboration with the patient and or their family. They've decided what they think will be the best outcome for the individual, and they really want to validate that with an experienced clinician. And that's something that they often don't get the opportunity to do. And it's really rewarding working sort of across organisational boundaries in this way to get the best outcomes for patients, for their families and for the system.